for us to note that suicide is not an easy topic to talk about, especially here in our country, or rather in a context where it is surrounded with a lot of silence, with a lot of stigma, and sometimes even shame. And as much as, yes, it is riddled with a lot of negativity, it is a reality that affects our families, it affects our ability to show up in the workplace, and sometimes it even affects entire communities. And according to recent suicide reports, suicide rates have been on the rise in our country, especially among the young people as well as men, which is a reminder for us that it is not just a private struggle, but an issue of public health. And with that, our goal today is to create a safe space to ensure that we break this silence as well as the stigma surrounding it. We're here to listen, we're here to learn, as well as explore together how we can recognize some of the warning signs or symptoms associated with suicide. Of course, support those in need and strengthen prevention efforts at our family level, workplace, as well as our communities. Allow me now to introduce our panel for the day. So we have Dr. Joseph Nyamiobo, a consultant psychiatrist here with us at Chiromo Hospital Group, Victoria Wambui Rika, a clinical psychologist, as well as head of corporate wellness. And then finally, we have Gathoni Mbugwa, a clinical psychologist, as well as head of digital relations at Chiromo Hospital Group. Before we begin, again, as a point of emphasis, we want to acknowledge that this conversation may feel heavy or even triggering for some of us. And if at any one point you may need to pause, it is very important that you listen to yourself as well as take care of yourself. And if you yourself or someone you know is struggling, we encourage you to reach out for help as well as services. So I'm going to link a number within the chat box that you can reach out for assistance, as well as for referral in the event that you know anyone that may require professional support. Finally, this conversation is for all of us. We'll have time to hear from you, our audience, through questions as well as reflections. So please feel free to make use of the chat box. Give us your thoughts, give us your insights, of course, respectfully. And at the end of our discussion, we're going to have a Q&A question. So maybe to our very first panelist, or rather to start us off, when we look at the silence around stigma, and I would like maybe to pose this question to Victoria. In Kenya, talking about suicide is often considered a taboo, and many people tend to shy away from these conversations. So why do you think that this is a struggle for Kenyans to talk about suicide openly? And what are some of the most common misconceptions you've seen within your practice, or either, within your workplace or as well as your community?
Thank you, Vivian, and a very good morning to everyone in the audience. So I think that maybe by defining taboo, we want to first of all say that a taboo really is something from the dictionary definition that is disapproved of, placed under a social prohibition or ban. But progressively, the term taboo has become less specific and describes something unacceptable or quite controversial, which suicide is. It is still quite a taboo topic in Kenya. And I would say that the existence of suicide-related stigma can likely be explained by the historical criminalization of suicide. So it is in itself a source of stigma, as anyone with suicidal thoughts, tendencies, or what we call ideations is considered someone weak, someone shameful, sinful, and selfish. And this also extends to the bereaved family. So we also realize that when suicide happens, it just does not affect the family, it also affects a community, like Vivian has already mentioned. So the stigma around suicide refers then to that mark that denotes a shameful quality in the individual so marked, and by extension, the family. We realize that suicide has a lot of connection with the state of the mental health of the person who has taken their life. And probably, again, because we have not made proper inroads where mental health is concerned, then people who are struggling with mental health issues are still labeled in one way or the other. Mental health is still quite stigmatized. Some of the myths surrounding suicide that we have seen is that there's one which says that once you confront an individual about the state of their thinking about suicide, then they're likely to be pushed further into carrying out the act. Like, for example, if you notice someone is struggling with your mental health and you ask them, are you contemplating suicide? Then that myth tells us that it is likely to push this person into actually carrying out the act, which is not the truth, because if you ask someone about the thoughts they are having and they are contemplating suicide, they will most likely feel that this is a safe space, this is someone I can speak to. You create an environment for them to feel psychologically safe, and they're able to open up about thoughts that they may be contemplating about a suicide. Then again, there's also the myth that suicide only affects individuals with a mental health condition. Well, this could be in a way true, because about 80% of people who die through suicide are usually clinically depressed. We also have what is called very impulsive suicide. Maybe because of lack of emotional regulation, you may have someone, you may have an argument with a significant other or with a child. You ask them about their grades, you ask them about playing truant from school, and in the heat of the moment, they may actually carry out a suicide attempt and succeed in the process. Then again, there's the myth that suicide usually happens without any warning, but in retrospect, when you look at it, there are subtle signs for someone who is contemplating suicide. Suddenly they want to give out their most prized possessions. They may also start talking about, they become overly obsessed with the issues surrounding death and the thereafter. They may also have tendencies which mimic clinical depression, like they may become very withdrawn, they become very isolative. If you look closely, their sleep patterns change, and they also look very withdrawn from their normal activities. So these are some of the myths that are there. And there's also one which says that for someone to take their life through suicide means that they're very selfish individuals who are only thinking about themselves. But remember, again, we are saying that someone who is suicidal could be clinically depressed. And when you're depressed, you're in no shape to really think in a very right kind, you're not in the right state of mind to make some decisions. And I think with that, Vivian, I would like to leave it open for the rest of the panelists to add anything that they may feel may support that conversation. Thank you, Vivian.
Thank you so much, Victoria, for the lovely insights. Suicide rarely happens without warning signs, as as Victoria has told us about some of the myths and misconceptions. And family, friends, and colleagues sometimes may notice that something is not going well, but even with that identification, they may struggle with knowing what to do about it. So maybe we can now look into the why, because we are seeing that, as we mentioned earlier, we are having rising suicide rates within the country, especially with the young and as well as men. And life comes with a lot of pressures. I think we can acknowledge that. When we look at the rates of unemployment, we look at the financial crisis, expectations around masculinity when it comes to men's ability to realize mental health, and even sometimes isolation. So maybe I would like to pose a question to Dr. Joseph. Within your practice, or rather within the Kenyan context, what are some cultural or even economic pressures that put Kenyans at a higher risk?
Okay, thank you very much. To begin with, when you talk about youth and men, I'll give an example of men. The male has a higher risk of dying by suicide. Studies have shown that 3 out of 3, after 3 death by suicide by men, there's usually 1 suicide by females, and females have a higher suicide attempt rate, which means that out of 3 females who attempt death by suicide, only 1 male will attempt suicide by death by suicide. This would mean that either men try suicide by very little means, or they also try suicide at a point where they are extremely unwell. So there is a harsh light on silent mental health crisis, which is fueled by a complex interplay, culturally, as you have said, economically and socially. When we talk about culturally, we know that men are expected to be very stoic. And when you're expected to be stoic, we're expected to be very resilient, we're expected to be the primary providers, and this discourages the expression of vulnerability. So seeking help for mental health struggles can be perceived as a sign of failure, leading many of men to suffer in silence. So there is this man-up culture, which often results in men turning to harmful coping mechanisms like substance abuse or even further exacerbating their mental health challenges. Religious beliefs can also play a role. So some interpretations viewing suicide as a taboo or sinful acts. This leads to feelings of immense shame and guilt for individuals contemplating suicide. And this can also lead to their families concealing the cause of death. So when you are maybe going to a death funeral and someone died by suicide, you will notice that there are a lot of harsh tones about the cause of death. This perpetuates the silence of the cycle of silence. When we come to economically, we understand that there's a difficult economical landscape. So there is high unemployment rate, there is high cost of living, there is also significant income inequality, and these are also major sources of stress and despair, especially for the youth, when we talk about the youth. So there is this pressure to succeed, which we can see very clearly from social media and print media. And this pressure to succeed academically and secure a well-paying job is very immense. And we know that the reality is that many graduates are being frustrated and are finding it problematic to get jobs. So when they keep on waiting on this problematic period, the responsibilities don't wait for them. So they are expected to be independent because they are graduates. This leads to feelings of hopelessness and worthlessness, making them feel like they are a burden to their families. So financial instability and inability to provide oneself and for one's loved ones, and the shame associated with unemployment are consistently cited as key triggers of suicidal ideation. For men who are also culturally expected to be breadwinners, the economic strain can be very acute. So if a gentleman loses his job and is unable to secure another one, this leads to a lot of identity crisis and a sense of failure. And this mounting pressure of debt is another significant factor, which may lead to suicidal thoughts, suicidal ideation, and death by suicide. When we talk about social pressures, there has been noticed to be a fracture in traditional support systems. So we have been moving from a traditional based culture to a more individualized capitalistic culture and urbanizations, which erodes the traditional family and community support. So this leaves a lot of Kenyans isolated and disconnected. So when they are in urbanized places, they're isolated. It's either they're living alone or with a partner or with a family. While back in the day, traditionally, there was a lot of family involvement, be it the nuclear family or the extended family. And this has led to a reduction in what feels like safety, in quotes, especially during times of crisis. So this, for example, when also we have interpersonal and relationship problems, this also is a major contributor when you talk about it socially, especially for young people. There are a lot of pressures for romantic relationships, a lot of heartbreaks, a lot of conflict with parents, and unrealistic expectations, which can be very overwhelming. So this breakdown in family units, domestic abuse, unresolved childhood trauma, we can say that these are one of the 3 reasons why socially, suicidal ideation, suicidal thoughts, death by suicide, and what people will call tedium vitae, which is almost the lowest form of in the continuum, where you're feeling continuously hopeless, helpless, and feel like if you are not alive, then life wouldn't be a bad thing. I don't know if we were to talk about early warning signs as well. And when we talk about early warning signs, we need to understand what are the risk factors. So number one risk factor is being of the male gender, because you have said after three males die by suicide, only one female will die by suicide, despite it being that 3 females might attempt suicide compared to 1 male. Age-wise, the younger you are, under 19, the older you are, above 45, that is also a risk factor. A diagnosis of depression is a risk factor. If you have had a previous attempt, that's a risk factor. If you are using substances, or especially alcohol, excessively, that's a risk factor. If you have what is called rational thinking loss, so you have what people call psychotic symptoms, to a point that you cannot rationalize things that are happening around you, that is already a risk factor for death by suicide. Also, social support, lack of social support. If someone has an organized plan, that is also a risk factor. Absence of social support to a point that they have no spouses. And also, what you have not noticed is that medical illnesses. So if you have, let's say, for example, diabetes, hypertension, cancer, there is a bidirectional relationship between these medical illnesses and mental illnesses and risk for suicide. Thank you.
Thank you so much, Dr. Joseph, for the lovely insights. Maybe I would like to further pose this question on symptoms. Maybe to Gathoni, you can tell us, are there any warning signs that maybe we can look out for in our families, in our friends, or even colleagues when it comes to preventive measures?
Vivian, I think Dr. Joseph has done a good and extensive job on that. However, maybe I would like to say there is what we usually call clinical red flags. And these are some of the things that we can help just do, like a short, quick scan. And maybe some of them have been mentioned. But usually if somebody starts struggling with their sleep patterns, or there's a change of their eating patterns, or they are completely withdrawn, you can be able to see like their behavior has changed in some way. So those could also be telltale signs, not necessarily directed at suicide, but to help us understand that this person indeed is in distress, whether it's an adult or it's a child. As long as there's a change in behavior, it's indicative something is going on. Then now this takes us to the next stage of how then do we introduce those conversations to create a safe space to talk and to be able to find out what exactly is going on with this individual, to be able to help them appropriately and objectively. Yeah.
Okay, thank you so much, Gathoni. Maybe now to our audience, I would like to encourage us that as we're listening into this conversation, maybe reflect on whether you've noticed some of the signs that we're being told about, either in yourself or even someone close to you. Remember, when it comes to addressing matters mental health, we all do have a part to play. So I have a part to play, you have a part to play, because when we do that collectively, then we're able to come up with very definite solutions to some of these issues. And maybe a further question to Gathoni, in your clinical experience, maybe how would you say that institutions such as workplaces, schools, as well as religious institutions, or rather, what role can they play when it comes to suicide prevention?
All right. Thank you, Vivian, for that. I feel like that's very, very loaded, but let's look at a breakdown. First of all, beginning with school, because that's the first line where people go through. So you'll find that because school carry the youngest and the most impressionable minds, it then makes it one of the best entry points when you're looking at any mental health conversations. Speaking about prevention, early mental health education integrated. I know a few years back, there was a mandate for all schools to have counselor or a psychologist that is not a teacher. And I think that just began shortly and the process was derailed. However, I do know from where I'm stationed at the schools along that road that definitely have counselors and psychologists who are not teachers, making it a safe space for students to be able to come and talk about their issues, and also people who are equipped to carry on proper referral. So being able to integrate age-appropriate life skills is very, very important. Being able to teach children in terms of emotional regulation and even stress management, because I think we imagine that children do not go through stress, and that's because we only see kids in distress a little bit, then it kind of looks like it has resolved. But children also go through stressors, and teachers are usually one of the first line people who are able to identify some of those. And my challenge is usually you need, as a parent, to have a rapport with the class teachers or the teacher, because if there's any change of behavior, it will first be noticed within the school setup. Secondly, is also to be able to equip the teachers to be able to identify exactly this is a warning sign and this is not just a child misbehaving. Okay, and also to encourage that if there are any warning signs, then they should be treated with compassion and not necessarily punishment. When we are also looking at the schools, we are saying that we also need peer support programs, training peer mentors. I remember when I was in high school, we used to have like a peer support club, but we are saying that we need to also now take it down, introduce these conversations to even the junior schools as well, at the mid-level school. And also the parental engagement. One of the challenges that I've also experientially had is sometimes you can go to a school, give a talk, and then be able to identify by virtue of a student coming to you and telling you they are struggling with ABCD. All right. And then you talk to the management and tell them, oh, this student came to me and this is what they said. Can we do something about it? And then you might find that actually parents refuse. They're like, no, I don't want my child to go through counseling. They don't have a problem. Or some of them even begin to feel shame. Like, why did they go and take our issues at home to the school environment? So I think also parental involvement when your child is within that very impressionable stage is very, very important. Let's look at the workplace briefly. 2023, the MOH, the Ministry of Health, launched the national guidelines on workplace mental wellness. And their strategy was to focus on promotion, prevention, and care and support, meaning that they did not just aim to respond to problem. They actually also aimed to reduce risk and build wellness proactively. So when we are looking at suicide risk, and we've had numerous cases of employees within the work environment die by suicide, and we can no longer continue to ignore that. So we need to figure out how can we be able to reduce that risk. One is to normalize conversations. When you look at work WhatsApp groups, you'll find that people will send every other thing other than check-in or other than have mental health conversations. Yet that is also a powerful space for people to be able to check in within their small groups. Secondly, every organization, I'm going to say that, needs to have an EAP program, employee assistance program. And if you're in this conversation and probably your workstation or your workplace does not have one, you really need to reach out to Victoria here, who is one of our panelists, or just DM us or write through any of the channels. So EAP programs basically come in to offer confidential counseling and referral services, which is separate from the work environment. So that way it also protects the employees. When we are looking at workplace, I also usually imagine that this is the only other space where we need to approach this conversation on suicide, risk, deaths by suicide, mental health, top bottom. Okay, once the people at the top, from the board to the CEO to the supervisors, line managers, etc., once they're able to understand mental health in general, mental wellness, overall well-being, then they are able to actually support the people under them. They are able to notice the distress and they are able to support. And sometimes one of the ways you can be able to know and notice that is also if there's a change in behavior in one of your colleagues, maybe absenteeism, they're a little bit more irritable than normal, or they withdraw. But also on the converse, we don't look at this positive symptom, but if they are overindulging themselves in the workplace, it could be also a sign that they are trying to escape, or they are functioning in terms of like burying themselves into work because of whatever stressors they are experiencing. And then one that is very controversial, but I've truly seen it in some organizations, is having flexible work policies, whereby rather than the leave days or the sick off, you actually are able as a supervisor or a manager to help your colleagues or your teammates or the people under you deal with mental health problems by giving them a mental health day. So that would also be very, very important. And the reason why I say this is because one of also the main risks when we're talking about suicide is also burnout. Okay, so if somebody is in a workplace where they know that when they are struggling, they can be able to get a day, even go for therapy, for example, that is not necessarily leave or a sick off, then I feel that it puts them in a better space where they feel a little bit more cared for. And then last but not least, when we look at religious institutions, obviously, as a people, Kenyans, the African context, religious institutions are usually the first line where people go and take their problems. So you'll find that they actually, for a lot of people, serve as what we call the extended family for many people. So there is not yet, because I was trying to do research, like a standardized national mental health policy for religious institution. However, I know there's a lot of work that has been done, even by Chiromo or even by churches, to start this conversation. But a lot more needs to be done. One, within the religious institutions, because these are what we call the family, the extended family. One, there are a lot of things that need to shift. That narrative of sin and shame shifting to compassion is something that is very, very important. This is a space where we can teach that suicidal thoughts, they are not just a moral failing, but also a sign of a bigger, major underlying distress that requires compassion, that requires support. Yes, 100%. The religious institution plays a role, but also saying, how can we get further help for this individual? This is also, being the family, a space that should also be first line to offer confidential spaces and even counseling. And then if it's not working, if you find that somebody is stagnating, then be able to refer them appropriately to the right person. And last but not least, because also churches and religious institutions generally do a lot of community outreach, this is also like the perfect place or the perfect spaces to use sermons, whether it's youth fellowships, women's group, men groups, groups for older people, to discuss mental health challenges, to discuss stigma, okay, and to also discuss strategies where people can work together, hold each other, visit each other, show up for each other without the fear of discrimination whatsoever. And not to mention also clergy training that has been extensively done. So basically, I'm just saying in summary that these three major key institutions, schools, workplaces, religious institutions, they already have the trust of the people. They already have the masses and the influence of the communities. So if they are able to move from that silent judgment to openness, to support, to clear referral system, then they can become the best frontline protectors against suicide and suicide risks.
Oh, thank you so much, Gathoni, for the lovely insights. Maybe just a double down question to Victoria, because we can acknowledge that as a country, we're still moving from the traditional to something that is more quote unquote modern, that is acceptable when it comes to seeking for help in regards to our mental wellness. So how would we encourage healthier coping, especially in traditional settings? Because we have to acknowledge that that is where we are coming from, and we are in a period of transition.
Thank you, Vivian. I think how we can encourage healthier coping is, first of all, by role modeling. Because even when we talk about families, we talk about workplaces. If, for example, we have what we call the employee assistance programs, and the seniors or the management is not making use of it, then the people below the managerial positions will definitely not make use of those programs. And what those programs intend to do, they intend to take care of our well-being by directing us when it comes to things like physical exercises, when it comes to financial investments, when it comes to how we handle or deal with our emotions. So if we do not role model the right kind of behavior, either to our children or to the people we are working with, then they will definitely not pick up on those good coping mechanisms. And also to approach the whole topic with a lot of empathy and less judgment, because if we do not understand our own feelings, then usually we will not be in touch with the feelings of the people who are around us, be they our children, be they our workmates. And empathy means that we understand what it is that they are experiencing. How are they coping? What can we do to help them cope better? If, for example, there's this particular person you've noticed who has regular outbursts, what is it that they're dealing with? Can we try and see what is below the surface as opposed to what we are seeing as a manifestation of what they're experiencing? So in a nutshell, what I would say is that we approach it with a lot of empathy, we go slow on the judgment, and we also do a lot of role modeling when it comes to how we cope. Over to you, Vivian.
Thank you so much, Victoria. I think now I will move over to the chat box, and maybe we can do a bit of Q&A before we finally look at the elephant in the room, which is access, systems, as well as policy. So maybe the first question I would like to pose to Dr. Joseph. John asks on the chat, is there a correlation between the level of education and suicidal situations?
Yes, thank you very much. Yes, there is a correlation between suicidal thoughts or mental health issues and level of education. Studies have shown that there's a big difference between suicide and national causes of death based on educational attainment. So those who had higher levels of educational attainment seems to have a higher levels of mental health issues and higher levels of suicidal and suicidal ideation and suicidal thoughts. We are not clear, or we don't understand really what this is all about, but we need to do more and more studies, especially in our setup in Africa, to understand why this is the case.
Okay, thank you so much. And maybe just a double down on that question. Someone asks whether you could, if it's possible to expand on how diseases like diabetes are a risk factor for suicide.
Okay. This is also very clear. We understand that, for example, the worldwide prevalence of depression, for example, amongst the general population is at 4.4%. When you think about something like chronic illnesses like cancer, depression rates are high, closer to 40%. When you think about depression amongst people who have chronic illnesses like diabetes, the rates go closest to 12 to 18%. So if you compare to 4 to 18%, that is a really big difference. Some of the reasons are, first and foremost, biologically. When you have a depressive illness biologically, I don't know if I am okay to discuss all these things biologically, but you have an increased amount of stress hormones in your body. Stress hormones in your body, and actually to a point that we have come to think that probably depression is also a biological illness due to increase of stress hormones. When you talk about psychological and the emotional impact of chronic illness, so people with all chronic illnesses will either have losses, either loss of physical function, either loss of autonomy, either loss of relationships, either feeling unhealthy, and this will lead to a feeling of chronic sorrow and grief. Also socially, we understand that chronic illnesses have a social impact and economic impact. So you have more financial stress, you are more isolated, you have difficulties with employment, you have to ask for some days off, you have difficulties with the daily activities. So all these three factors may explain why the prevalence of a common disorder like depression is higher from 4% in the general population to 18% in people with depression, and all the way to 40% in people with cancer.
Okay, thank you so much, Dr. Joseph. There's a George on the chat asked, is there a Kenyan toll-free line? So we do know of different organizations that do offer a free toll-free services. So such as Befrienders, Red Cross, as well as Chiromo Hospital. You can always reach out to us, as Gathoni mentioned, on our different platforms, or even write to us, and then we will be able to be of assistance. So we can now finally talk about solutions. Now that we know in Kenya, access to mental health care is limited. When we look at the number of professionals or other mental health practitioners, when we look at the cost of services, as well as stigma being a key factor when it comes to reaching out for help, yet families, schools, workplaces, and even religious institutions can play an important role in prevention. So maybe I can pose this question to Victoria. So at a communal level, what do you think we can do as communities, of course, without shame, when it comes to helping the people around us when in terms of reaching for professional help that we are realizing is a bit difficult to access?
Thank you, Vivian. While we have not been able to reach that poor Mama Mboga in the village when it comes to issues with her mental health, we've tried to make inroads. And how we do that is by partnering with CBOs, the community-based organizations. The government has been of a lot of help, and what maybe we could do better is have, like what Gathoni has mentioned, implementation of gender-specific suicide prevention strategies. Could we, for example, have gender-specific kind of groups or meetings, like for the men? You know, men usually will not talk about the issues they're struggling with. They'll suppress them. And one of the way we realized that someone, a certain man was going through mental health issues is when they die through suicide. So if we could have that implementation, and then also if we could have rural vulnerabilities to be addressed, because there are suicide cases that we do have even in those rural areas. So how can we do that? And I think it is by integrating mental health in primary health care, which again, the government has attempted. But again, what we need by integrating primary health care is that at the local level, where we have the GPs in the medical centers, we can have them check into the space or into the status of the people coming in as outpatients on the state of their mental health. We did some research as Chiromo Hospital Group, if we recall, and we realized that most people at the outpatient facilities are there because they're suffering from a medical condition, but in reality, they also have an undiagnosed mental health condition. So if we could have that at the primary healthcare level, that they check into the mental health status of the people coming to the facilities, then I believe we will have lesser cases of suicide. So if we could have an improvement on that in mental health service accessibility, and also probably have more professionals at the grassroots, psychology, psychiatrists, and psychiatric nurses, then I think we can make a better inroads when it comes to taking care of mental health, which will help in prevention of suicide. Thank you, Vivian.
Thank you so much. And just to go back into the chat very quickly, maybe to Gathoni, there's a follow-up question on, as it now, what is the legal position of suicide cases in Kenya? So maybe that will be the first question that I could implore you to answer. And then the following question will be, is there a correlation between geolocation and suicide? And if maybe of any research, which counties within the country are have leading cases of death by suicide?
Thank you, Vivian, for that. Can you hear me?
Yes, we can hear you.
All right, perfect. I'll start with the first one. First of all, allow me to start by saying that when we looked at our law, specifically when we looked at the penal code, I think it was section 226, if I'm not wrong. This section actually made suicide attempt punishable. It made it a misdemeanor for a person who attempted to kill themselves. And the penalty was actually a fine or serve a period of up to 2 years or even both. Okay. And when you actually go into the law and look at that, you'll find that the minimum age for prosecution was actually also low, as young as 8 years old under the law. The good news is a lot of work through the Ministry of Health, the Kenya Psychiatric associations, individuals, friends and partners, they came out to do some work in terms how can we be able to repeal that, and even we as a hospital who are also part of that. So the good news is on the 9th of January this year, 2025, finally the Nairobi High Court was able to declare this particular section 226 unconstitutional. So this actually means that attempted suicide is no longer crime in Kenya. Okay, this is very good news because we actually say if somebody has attempted suicide, then it's an emergency, a psychiatric emergency. They should be in a space where they get treatment or observed or are spoken to. And I believe that with this repeal, we are going to be able to collect even more data, number one, and most importantly, we are going to help address a lot of the cases that are coming in, whether it's because of individual stress or underlying mental illness, but basically we are going to be in a position as clinicians, as a people, to help people, because there is no longer that fear that you're going to be punished or you're going to be jailed or there is going to be a fine. However, a lot of work still needs to be done, even though the law has set this framework for us. A lot of work still needs to be done in terms of creating awareness and breaking stigma so that people can come out and have these conversations or seek help openly. Yeah. So allow me to invite Victoria to answer the next question. Victoria?
Thank you, Gathoni. Is that on the sample of the employee support program?
The follow-up question is on whether there's a correlation between geolocation and suicide. And in that case, maybe according to research, are there any counties within the country with leading cases of death by suicide?
When it comes to the statistics, I think because of the taboo nature surrounding suicide, we will not always get the correct statistics. But from World Health, what they say is that suicide happens in the lower socioeconomic countries. But in terms of Kenya, I may not be able to respond to that. Dr. Nyamiobo, you may have a response to that. If not, then we can check later and probably respond appropriately.
Yes, I can have a response to it in a certain way. First and foremost, there is a lack of studies about which demographic areas or geopolitical areas have higher death by suicides. But according to studies worldwide, close to 70% of deaths happen in low and middle income countries. And the commonest cause of death by suicide is by organophosphate poisoning. So that will mean that places that are agricultural zones have a higher incidence of death by suicide. But that is not to downplay that there is also this geopolitical class of people who have access to lethal means. So people who are probably in the disciplined forces, they have access to guns. People who are in the medical field, they have access to lethal ways of injuring themselves with medication. Those are the groups that, in my opinion, are highest in the risk of possibility of death by suicide. Also, to echo what Gathoni just said, we are very happy as a country that the government has done a very good job to decriminalize suicide. So that is to mean that nowadays we don't talk about it as if we say that someone committed suicide. Because when you say commit, it means that it's a criminal offense. So either you can commit murder, you can commit a traffic offense, but you cannot commit suicide. You can probably die by suicide or have a suicidal attempt. I think I have tried my answering.
Thank you so much. So someone on the chat asked if we can get a sample of an employee assistance program. I have shared a number on the chat box as well. So you can kindly reach out to us and then we'll be able to avail that to you. And then very briefly, maybe Gathoni or Victoria can chime in on tips on how to support a sibling dealing with unemployment and occasionally has suicidal ideations. As well as someone asks, this is a very specific question, how can lawyers help with prevention of suicide? For example, sort of protecting the right to feel, express distress, set boundaries without fear in society and workplaces, as well as family dynamics.
I could start. There are 5 key things usually when I'm discussing with my patients, that what we call like a family checklist that I usually share. And I think this is a good space to share that. So first and foremost is listen to understand. So whether it's siblings or parents or whatever context, but listen to understand and not respond. I feel like a lot of people, whether you express concerns about joblessness or whatever it is, you can't wait for that person to finish so that you respond or advise them or tell them whatever it is. And sometimes people just want to express their frustration. So first and foremost is listen, validate their feelings, listen to be able just to understand where are they coming from, do not interrupt, do not judge, and basically just express, I hear you, and then even just get into what else can you be able to be done. Secondly, in that checklist is usually like do a check-in. If somebody is already in distress, if somebody is already struggling, just because you had this conversation today does not mean that they have resolved everything or they have settled. Please do regular check-ins, calls, text, sit with them daily, and physical presence is actually also very, very important. So these check-ins usually just continuously it inform that person, whether it's a child or a sibling or whatever it is, that they are not alone. So 1 is listen, 2 is checking, 3 is create a safety plan. There's a lot of fear within the family context of asking somebody directly, are you thinking of harming yourself? And a lot of parents have been able to engage into that conversation and it's worked. I've actually had feedback where a parent would see maybe a child, their teenager, they are not okay, their mood is not okay, and then they ask the question directly, or even their sibling, that are you actually thinking of harming themselves? Actually, when you do that, then you actually create that safe space for them to be able to tell you what it is that is going on. And in that space, you also need to, if you already know somebody is struggling, then you need to remove means around them. okay? Whether it's medications, whether it's knives, or whatever means it is. And just also reassure them that you can either go back and see your counselor, or what do you need me to do, or can I sit with you? But basically just create that safety plan. And then the fourth one is encourage healthy routines. And then the truth is sometimes when somebody has depressive symptoms, or they are feeling low, or they are feeling frustrated, it's not uncommon for any human being to try and figure out how can I cope. And sometimes people are likely to go into unhealthy coping mechanism. So please help encourage healthy routines. And at the top, one of the game changers is usually like physical activity. But other than that, just check, how are they sleeping? How are their meals? And just small daily goals, and be able to celebrate every small step. And then the fifth one is absolutely 100%, just connect them to a professional. Therapy, counseling, or any form of a support group. What I usually say is that just help people around you to understand, to focus on the effort, not the outcome. And I know, obviously, I do want to acknowledge that the outcome is, I need a job, I need to take care of myself, I need to meet my needs. I acknowledge that that is very, very important, and I would not want to downplay it. However, also, what is the effort that you're putting in? Because as long as you're putting effort, maybe you're applying, maybe you're going online, probably you're doing even the small free certifications. If there is that effort, the outcome eventually will come. But you have to hold yourself responsible, and you have to support the person next to you to kind of still keep putting in the effort. What was the other question, Vivian?
Well, I think you've answered very comprehensively, because if we're looking at how to support someone with suicidal ideations, how to create a safe space for for expression, for someone who's struggling, I feel like your answer was very comprehensive. But
That in the
maybe,
chat.
yes, thank you so much for the insight. I think now I would like to welcome some of our doctors in the audience to give their insights, or rather chime into the conversation. I don't know if we have Dr. Charlene on the call. Okay, if not, then I would like to extend a very warm welcome to our panelists for such thoughtful conversation. But to tie it all in, I would like to invite our chairman, Dr. Frank Njenga, to give us his reflections on the topic of suicide, where we have come from as a country, where we are, and what the future looks like for us.
Okay, I will start by saying where we have come from and where we are. We have come from a very dark place where people would not even consider talking about suicide, to today, where we had almost 200 people in this particular session listening and contributing to this all-important subject, number one. Number two, we are at a point where the clergy who are on record of having refused at one stage to bury a spouse of one of their own are now completely available to education on the matter, on this very important subject of suicide. And it's not a secret that next week, I think on Monday, the Interreligious Council, the government of Kenya through the Ministry of Health, the Aga Khan University, the Chiromo Hospital Group, KEMRI, through Dr. Lynette Ongeri, among others, are putting together their thoughts on this whole subject of suicide prevention. What am I saying? I am saying that we as a country have made tangible steps in the direction of dealing with this very important subject. This is Lynette Ongeri's PhD thesis, which came out sometime last year. So there is no shortage of good news. Well, perhaps not so good news, but there is no shortage of knowledge and information around this whole subject of suicide. Let me close off by saying that although the High Court, very wisely, in my view, declared Section 226 of the Penal Code unconstitutional, we still have to go to the next logical legislative step, which is now to remove that particular provision from the law. It has not been removed from the law yet. So the work is, most of the work is done, but we have not finished because legislators must now do what they're paid for, which is to remove that particular provision from the Penal Code. In summary, therefore, Vivian, I want to thank you. I want to thank your team. This is probably the best discourse on this subject that I have ever heard anywhere in the world. And so congratulations to all of you. I have been around a little bit and I do know quality. And today what you have given us, Vivian and your team, is nothing short of international quality. And I've seen somebody asking for a recording of this matter today. And I think you should make it available to other people because it's very, very well researched, very well thought out. Congratulations. Thank you. Goodbye.
Thank you so much for the lovely insights, Dr. Frank. And the recording shall be made available at the end of this session via our YouTube channel, which is Chiromo Hospital Group. Yeah. Maybe I can invite our panelists to give us any closing remarks in regards to our topic for the day. Maybe we can start with Dr. Nyamyobo.
Thank you very much. It's really difficult to talk about such an important person in life. But if I was to say something that I shouldn't say to anyone else, is 5 things. For your mental health, Gathoni said it very clearly. You need to be very proactive about making sure that exercise is part of your life, that adequate sleep is part of your life, a reduction of toxins in your body, having very good diet, and also being in a community where you feel like you belong. All these things will help in promoting and preventing mental ill health, to a point that we will prevent suicide as well. Thank you.
Thank you so much, Dr. Joseph. Victoria?
Thank you, Vivian, and to my co-panelists. There's a quote that I always want to leave an audience with when we are talking about suicide. When I've been talking to suicide survivors, they always say that I did not really want to die, but if my problems were not there, then I would still want to live. So in a nutshell, what's the quote is that suicide is a permanent solution to a temporary problem. So for anyone out there thinking suicide, remember that there is always hope. Thank you, Vivian.
Thank you so much, Victoria. And then finally, Gathoni.
Okay, first of all, Vivian, thank you. You've done an excellent job in moderating us today, and to my fellow panelists. Mine is to say that one conversation can change the story. One conversation can save a life. And in line with the theme, which is changing the narrative, I would just like to challenge all of us, starting from every single individual who is here, to start by creating that safe space. And to anybody out there who is struggling, just to remind them that even in these dark moments, hope is possible. Thank you.
Thank you so much, Gathoni. As we wrap up, I would once again like to extend my sincerest regards to the panelists, as well as to the audience, for being very engaging and for your thoughtful contribution, and for contributing to this conversation. Our key take homes is that suicide is preventable, and each one of us has a role to play. So by breaking the silence, looking out for any potential warning signs or symptoms, supporting each other with compassion, and of course, pushing for stronger mental health systems in Kenya. As a point of emphasis, if you or someone you know is struggling, please reach out to us on via the number on the call, which is 0743 894 164 for professional help, because help is available and recovery is possible. On behalf of Chiromo Hospital Group, I would like to thank you for joining us. Let us continue having this conversation at our individual levels. And I'd also like to extend an invite for next Thursday, same time, where we will be furthering this topic on suicide. Thank you once again, and I wish us all a lovely day ahead.